Welcome to the Aid Market Podcast, where foreign aid partners connect to learn about key funding trends and market insight. The podcast is co-hosted by Aid Connect Data, the pipeline and market intel software for USAID partnering, and Connected International, the leading USAID partnering support consulting firm. Now, here's your host, Mike Shanley.
Gorma, welcome to the Aid Market Podcast. We're very excited to have your organization co-hosting our conversation today with Dr. Brown. Could you share with our listeners a bit of the important work that you and your team are doing in global health in West Africa and particularly in Liberia?
Yeah, thanks. First of all, I want to say thanks for the opportunity, Mike, for taking time to talk about the work that we're doing in Liberia. Care Africa Medical Foundation is a nonprofit focused on health. We started out as just a visit, my husband and I, and then we realized there was a major need in the county that we're from. We say county, the U.S. is state. So in Bassa County, where we were born and raised, we realized there was a need for health. The only governmental hospital in that region had burned down more than twice before our visit. So we decided to start conducting free health fairs in school buildings and all of that. When we leave, people still have needs. It was not enough, so we needed to do more. So when the opportunity presented itself for a facility, we went ahead and rented it, renovated it, and opening our first medical center in Bassa. Coming the spring of 2025, we'll be opening it in March.
Excellent.
The health center will focus on, we have a female ward, we have women and children ward, we have a male ward, a small OR, labor and delivery, ED department, full laboratory and full pharmacy, and outpatient as well. We'll be conducting some outreach. Buchanan is a very vibrant city, but health needs there is very vast. So we decided to help out the best way that we can. Is more touching to us because it's home. I know the next door neighbor, they know my family. I know the road that I used to walk to go to school. So it's personal for us. Then meeting Dr. Brown was just a plus to be able to join the team and help out the best way that he can with surgeries and just oversight as well.
That's great. And looking forward to that conversation. Could you share with our listeners how they can best support your organization and how they can connect with you and your team?
Okay. So we are on Facebook. We're on LinkedIn. It's called Care Africa Medical Foundation. I can be reached. The contact would be in the link as well. For our contact information to be able to reach us. Right now, our focus is just trying to get this facility up and running, fully equipped with every necessary things that we need. Mm-hmm. On the line of helping, just picture a building with nothing in it right now. So it's fully done. All the rooms are there. They're ready for function for our operations, but we're in need of supplies, equipment, consumable volunteers that want to go to Africa, help teach, educate. All of those opportunities are available for people to help. If someone is interested, they can reach us and we'll be able to partner with them.
Wonderful. So anyone, doctors, medical professionals that want to volunteer,
yes.
Anyone with high quality surplus medical supplies and or consumables,
yes.
To reach out to your team through
yes.
the website.
Exactly. Through our website, the easy email address is info@camedfoundation.org.
Great.
So info@camed.foundation.org.
Great. And for anyone connected with me on LinkedIn too, feel free just to message me and Gorma will put them in touch with your team as well.
Yes.
Great. Well, truly thank you for the important work you do for the people of Liberia. And thank you for setting up and co-hosting this important conversation today with Dr. Brown, where we'll talk about a bit of the work he'll be doing with your organization, as well as the other important work that he's done in the past. So, Gormer, thank you very much for joining us today.
Thank you, Mike. Thank you.
Dr. Brown, welcome to the Aid Market Podcast. It's a privilege to have you here today, and I've been looking forward to this conversation for a while to learn from your important experience in global health work in West Africa and in Liberia specifically, but also to hear your thoughts for global health professionals around the world on what lessons we can learn from the Ebola crisis, from COVID-19, to be better prepared for the next pandemic and for the next the global health needs of the future. So to start, could you please share a bit about your experience and the important work you and your team did during the Ebola crisis in West Africa?
Thank you, Mark, for having me, and it's an honor to be on your platform today. My name is Dr. Fahnloe Brown. I'm a general surgeon with public health background in healthcare policy and management. I'm married with 3 children, and my wife is one of my strengths in terms of support in what I do. And I'm happy to be here today. There are a lot of work we've done. To be specific, if you want us to talk a little about the Ebola crisis, and I would tell you that during the Ebola crisis, our primary goal was that of humanitarian, to see how best we could help save lives and contribute to the control of the epidemic at that time. And so it was not based upon monetary value that we could get in or some basic insurance coverage in terms of the danger we found ourselves in. Because none of such existed. But we felt we were to get involved considering the threat the disease was posing to our community, our country, and the world at large. And so our primary goal was of 2. 1, to first see how we could provide care for patients that were involved, and later we found ourselves involved in research at the tail end of the crisis, looking at different therapeutics to see how they were effective in the care of patients that were brought to our centers of care. It all started with our chapel. The chapel at that time was a small space built on campus, not really a church, but in the form of a church, where we went every morning from Monday to Friday to have morning devotions. And we used that to pass on messages to our employees at the ELWA Hospital and to at times do training. That's what the chapel was intended for. But when the crisis came about and it was difficult there was no time involved to construct an isolated unit or isolation unit, and no time to think about where to get one. And then I was serving as the medical director for the ELWA Hospital then. And it was challenging for the other administrators to have engaged me and said, Doc, what do we do now that we have such crisis on hand? The goal was having somewhere where we could isolate one of our staff and or isolate patients that we may have accidentally until we can have them transferred to centers that will be established by the government, since it was a national crisis. And so that was our thought initially. Only to realize that the isolation site we set up to serve the sole purpose of attending to our staff and or patients we just encountered suddenly turned out being the first isolation unit in country. Because I remember when I first said to the team in the chapel that we're going to transform the chapel into an isolation unit, there were a lot of criticism, of course. What does he want to use our chapel as an isolation unit? He can't think of anything else. Now he wants to use his missionary to come up with things that doesn't make sense. But initially, at the genesis of crisis, people who do not have vision don't see the future. So when we begin to tell them about impending danger, it doesn't make sense to them. And that's what was really happening. But we went ahead, despite the criticism, despite what people said, and went ahead and still kept the chapel. I remember many other institutions who attempted establishing an isolation unit shut them down when the first case passed through Liberia in April, and we managed to control that. So those areas were shut down. Ebola will continue in Guinea, and it's going to remain in Sierra Leone. But there was one thing I said to my colleague, my missionary colleague, and other senior management team, was as long as we continue to have Ebola in Guinea and Sierra Leone, we stand the risk of having it. Because of cross-border activity, there are intermarriages between Liberians and Sierra Leoneans as well as Guineans. And so when things gets rough in any of those neighboring countries, there's a high likelihood that they'll come back home. And so it never took long. In June, we had our first set of cases. And I remember being called by the Minister of Health then, Dr. Dan, asking whether we had shut down the isolation unit we had at the center. And I said, no, we still have it. We still have the chapel available. And that was the beginning of our involvement with Ebola patients. It was then Dr. Ken Brindley, an American family medicine physician, was asked to spearhead the team together with Dr. Deborah Hasselner, a general surgeon, American also, while I remained in the hospital conducting surgery and doing other medical activities with others, because we all could not go into the unit then. Unfortunately for us, our colleague got infected, and they had to evacuate them to the US. That was, we were still at the chapel, and that is what is referred to as the ELWA Ebola treatment unit. But the country later became overwhelmed with the number of cases, and the chapel began to receive, there was no bed space now within the chapel. We had situations where we were waiting for another person to pass out to create bed space for others that the Ministry of Health or other will call us to tell us about. And so the next thing was, what do we do next now that we're running out of space? And so in our administrative discussions, we decided to use the hospital laundry in the hospital kitchen to transform it into an isolation unit. As I said earlier, there's no room for construction. So the best option was to use available structures. So we then got a system from the Ministry of Health, and then look at we did a walk through the teaching and laundry. With help from WHO, we transformed it into an isolation. We were tackling within a week. And I remember it was within that week that Dr. Brindley got infected, because they only helped to transfer the first set of patients there, but he was not around to continue working in ELWA 2, which was now the kitchen and laundry. And this now, at this point, we could take up to 50 or more patients at one time, unlike the chapel where we could take between 6 and a maximum of 9 patients. And so Brindley and others had to leave. Then the situation became worse, because there was now no doctor at the new unit we established to kind of provide direction and leadership on how to care for the patients and the way forward. And all of the other doctors within the hospital were afraid and no one was willing. And the situation now was like, look, Dr. Brown, you need to shut that hospital down because other hospitals were now closing. You need to shut the hospital down by the time they will close and forget about offering service. But this, you know what I said to some of them, I asked them a series of questions. Look, they agree, we shut the hospital down. Your wife or kids got sick at home and they need medical care. You treat them at home, or where will you take them? But if we had this place open, you have a chance of having your loved one cared for or taken care of beside others. If we shut the entire health system down, what happened to people with other disease conditions? Other than Ebola. People come in and want to give birth. People have other things like ectopic pregnancy we saw in our unit. What happened to them? Do they all die because we have Ebola crisis? No, can't do that. And especially so when our American counterpart were willing and coming to make sacrifices, like that of Dr. Sequelae and others who came, I was like, why should we run away when the others are there trying to help us? And people coming from other places that can be in country now to help us. Doesn't make sense. We managed to talk to them, a few agreed. It was at that point that in June 19th, and that was my first date of entering the unit. And then mid-July, I decided to leave things within the hospital for a while because the staff at this isolation unit I decided to move out. Some decided not going to work again until they understood how Dr. Bradley and others got infected. And so there was no leadership. I then moved in. Quickly called a meeting and said, look, come, let's work together and see what we can do. And it was challenging because my wife, of course, had told me already, don't join it. Can't wipe me, do not join the team, do not go into that unit. I said, yes, ma'am, I won't. And so for the first week, I formed myself into the unit. My wife had no knowledge. And I never told her. But I managed to get the team back together, spoke to them, so we can make it. As a matter of fact, when we started, one good thing we did was that Debbie, together with others, trained everyone within the facility on how to put on PPE, protective garment, safety measures. We train everyone, irrespective of your area of assignment, accounting, cleaner, technicians. We made everyone be trained so that when there's a need of shifting you from somewhere else, or you had to put on a travel suit to get certain things done, it won't be a strange thing. The other thing we learned was it's good to make use of what's available to get things done while you wait for help. But what I mean, we never had travel suit to train one another. But as a surgeon, and Debbie also a surgeon, one thing we knew was to execute safety measures whenever we're conducting surgery. So we brought our OR gowns and began to teach people on how to safely wear the OR gown and kept safety and ensuring safety for the patients we attended to. That's why we began to teach people, look at a few policies from MSF and other things, and started with it. And so when Dr. Brennan left, we then began to just read on other infection prevention measures that we saw online from WHO, other places, and begin to execute things. Because back then, the WHO and others were still making plans. CDC, USA, and others were still making plans on how to come in. But people were sick, people were dying, you can't sit and wait for them to come in, so you had to do something. So with that in mind, we got started at the treatment unit and began to provide care. What was astonishing initially was the level of care provided to patients then. For me, as a surgeon, having learned about management of shock and seeing many of the patients presenting with the signs and symptoms of shock, that was the first thing that captivated my attention. And look, we're not treating these people well by following policies that people had or issued within 3 feet distance from the patient, don't have much interaction with them, and we're only providing fluid, trying to prevent ourselves from doing invasive procedures for fear of getting infected. But this is what we ask ourselves. If the taric suits that are being supplied are protected, and indeed the virus cannot penetrate them, and we see no reason why we can't touch this patient. There's no reason why we can't get closer to them. If we took them out safely without getting ourselves contaminated, there should be no reason why we should not touch this patient. So my first goal was to change the scope of treating patients in shock with oral fluids. What we learned in school is bolus IV fluids, not oral. So we begin to establish IV now.
So as part of the challenge then, countering disinformation within the communities, but as well as within the healthcare professionals?
So it was, we had to change the scenario from maintaining distance to establishing IV access. So we made a policy that everyone entering the unit, irrespective of your condition, will establish an IV access first. Because the time they took for a stable Ebola patient to transition from a stable condition, looking at you talking, to a sudden state of shock, was no time. And we had not been spending much time within the unit. The maximum was 44. If you stay there for 45 minutes, then you stay longer. But I stay like 1 hour or more, because we never have, if you can have like 20 patients and everybody outside. So by the time you got back in within 2 or 3 hours later, patients you encountered initially, condition had changed. And it became more challenging to establish an IV access on a unstable patient compared to a stable patient. Mm-hmm. So the goal was just establishing, don't worry, to establish. When the patient becomes unstable, we give fluids. So that's the first thing we started doing. The other challenge was we never had means of diagnostic capability. There's no laboratory. There was no laboratory within the unit at all. You could not collect sample from the unit and carry it to the hospital lab for testing. The only sample collected from the unit was for confirming Ebola positive or negative. That was the only thing we could do initially. And so we had to come up with means of determining whether somebody was going to acute renal failure, by trying to measure their urine output. We never had things like Foley catheter and urine bag to apply and measure urine output. This was not possible. So I had to ask people to avoid urinate in larger mineral water bottle. So that if you want to urinate, do not use the restroom. Urinate in this dish, and when you come back, we want to see it. That was to determine the volume of urine being produced by the patients, and that enabled me to begin to say, this has developed acute necrosis, and based upon the color of the urine and the volume produced, we were just using our own thought and inventions on how to best attend to the patient. And the other thing was there were guys providing, real care for the patient, like nursing care, bed bath. It was difficult to do so for someone who is considered to be Ebola positive. But if beside the disease condition itself, we realized later that the mental trauma from the disease alone will also happen to cure.
Mm-hmm. You mentioned several of the international organizations, the multilaterals, WHO, CDC. A lot of our audience are the decision makers at those organizations, at the large NGOs. Their priorities in various ways, but globally, is localization. They want the funding, the power, the influence, the decision making to be made as locally as possible.
Great.
As they're developing, and it's evolving policies under the general name of locally led or localization, what would your advice be to those policymakers, both at those donors, but also at those large NGOs and implementing partners, on how they can most effectively make sure their resources are maximizing the impact of them and really helping organizations and the work that you and your team were doing?
One thing I would say first of all, thank you for that question, is that I think our international partners first need to understand what the national health plan of the country is all about first, and see what the government has in terms of the provision of quality health care for our people. And so that we don't run parallel services, rather the services that we are coming to provide, meaning our international partner, conform with what the government agenda is. Because if there are parallel policies or plan, I think we will find it difficult to work as a team. And teamwork is very essential when it comes to improving providing quality health services. Now, having understood the government agenda and plan, then you can now decide on where to direct your funding. However, what I've seen over the year is that some of the plans that are put together by our international partner, some do not conform with the government national agenda or plan. Notwithstanding, because they have the money, they enforce what their agenda or plans are, and not what the country or the people are thinking about doing. And so we saw that happen in some instances. So I think that is one thing to also try to figure out. What do the people want?
So making sure even at the design, the project planning stage, the funding allocation stage,
yes,
to have those voices of the clients, the people you'll be working with, engaged at that phase.
Yes, or even visit them.
Mm-hmm.
Visit them. Look at their health sector. See where the pitfalls are. What are their strengths? And then you can take advantage of that and come up with a plan. Say, for example, in Liberia, there is no IV fluid plant in Liberia.
Mm-hmm.
We don't have a single plant for producing IV fluids anyway. IV fluids are brought in from other countries. But you came and chose to perhaps build a fabulous hospital when IV fluid is still going to be bought from outside. A simple thing like IV fluid is not available. If we had a pandemic now, wherein the patients will require massive fluid resuscitation, going to run into crisis.
That's the next thing I wanted to ask you. How prepared do you feel, both West Africa, but globally, the global health ecosystem is for another pandemic?
I would say to some extent it's a yes and no thing. Yes, to some extent.
Better prepared than pre-Ebola, pre-COVID. Okay.
Globally, we are prepared than pre-Ebola and COVID. In fact, there are a lot of things we learned from Ebola that enable us to combat COVID.
Okay.
Yes, safely, in that many of the public health measures that we used during Ebola, or that came about or emerged or developed during our fight against Ebola, were very useful when COVID came. For example, contact tracing. It's a very useful thing. Risk communication became very useful. Okay, case search. And those things were things that we learned, developing an organizational structure in terms of how to combat the outbreak. But all things developed during Ebola. So when COVID came, it was easy to refer to them. And then it got started. And those structures or systems are still in place. So that's a plus. However, there is still not equitable access to health products and supplies. And also, there is still not equitable, I would say, health financing globally. There are others that have more strength. There are others who do not have.
And would you say even within Liberia that
Yes.
it's not equal? Or are you talking globally?
Global.
Okay.
Okay. I'll give you an example. With all of the crisis we had in the sub-region, Liberia is still struggling to ensure that our major reference lab become a level 2 lab.
Mm-hmm.
Whereas in Guinea, they do not have only a level 2 lab, they have level 3.
Mm-hmm.
Okay, but we're still there. How? I still may not understand, but I think it also comes back to how resources were allocated. Okay, how those resources made available were used or directed. The other thing I see the other thing I've seen is that it was impressive when I attended the World Vaccine Conference in Washington earlier this year to see how scientists are working on frantic efforts to come up with therapeutics, to come up with vaccines, to come up with different mechanisms of how to combat any emerging disease in the future. I think that's a good thing that globally we should continue to do. And so that's a good beginning. We need to continue that. However, I think another advantage I've seen is that we never had what we call the African CDC prior to Ebola, but that body, along with other related organizations, have emerged and are now doing everything possible to work with countries to develop preparedness agenda and or help countries that already have preparedness agenda to improve on it and getting them ready for any epidemic in the future. That's a plus globally. Okay? But what I don't see us doing is that we're not trying to go after the sources of the pathogens. What do I mean? If you look at Ebola or maybe COVID, it's been said that many of these diseases have zoonotic origin. But we're not doing anything to reach out to where those animals are, to come up with research mechanisms of how to see what's lying out there. Because many of these diseases are there, not that they do not exist, but they are in a quiet corner, paying attention to themselves until we provoke them. except we provoke them, they don't bother us. Like now, we find ourselves promoting, we may not be promoting the people, let me take that word back, but we have global crisis. Like one vivid example is the one in Sudan or the one in Gaza. With the situations in those countries, there will be some pathogen lying by itself, not bothering us. But because of the absence of good access to safe drinking water, the quest to find something to drink, someone could just ingest something that no one had ingested before. And that could be the beginning of another crisis.
So even conflict can lead to the next global health crisis. Dr. Brown, you were on the cover of Time magazine. You were named, along with the other Ebola fighters, Time magazine's Person of the Year. In preparing for the interview, I went through the list of past recipients of that. They include Gandhi, Martin Luther King Jr., last year Taylor Swift. Being named to that, one is I'd love to hear the story just of how you become notified of that, of an award. When we had some of the Nobel Peace Prize laureates on here, they shared how they got the call. But then more importantly, get into what does that mean for your work, and how has that award and platform affected your ability to do work, fundraise, share your message globally?
Thank you, Mark. The issue of being placed on the cover of Time magazine was a big surprise. I never had the slightest knowledge of ever being there, because all we were doing was work and work and work to save life. That was my goal. The journalists from Time magazine who came or went at the unit to interview me took 3 days before she could finally get me to sit. And I admire her determination. The first day she engaged me, I was like, I'm busy. I have the chapel, I have patients to attend to. I have to come back to the hospital to do surgery, and then we went back into the unit. So no time to sit. And I thought that would have discouraged her. But the first day she went away, she was just taking pictures around. The next day I encountered her, I said, okay, don't worry, we'll do it tomorrow. And when the third day came, I still wanted to avoid her, but I said, look, I must give this one more word. And that's how we did the interview. She never told me what purpose it was intended for or nothing. She left. So it was in December, early morning, getting ready to go to work. And trying to dress. Then my phone rang. And I looked, it was a foreign call. So I decided to answer. Took the phone. And then the person said, congratulations. You've been named Time President of the Year. And I'm like, what does that mean?
Did you think it was a joke right away? Or?
Yeah, I said, what do you mean? So I'm telling you, you're on Time magazine cover. So I said, who told you? He said, no one has called you? And I recognized her voice. I was a journalist who visited me. I said, no. And then I paused. Why? That was the answer. So what is supposed to mean to me? She said, it is a remarkable achievement for the work you've been doing. I said, okay, thank you very much. And I was done with her because I felt I was getting late to run to the unit to go and attend to patients. And then my wife, I just got out of the shower to overheard the discussion and said, who was that? And someone called me to say, I'm on Time magazine and some Time President of the Year. I don't know what she really means, but we'll figure out why it's later on today. We just hurriedly got dressed and off. Then during the course of the day, later in the afternoon, a journalist called me from the national radio station and said, Dr. Brown, congratulations! I said, about what? He said, man, I'm proud of you. On Time Magazine, just got it. News on social media. I said, then I decided, I think I need to check and find out what these guys are talking about. It was then I decided to go back. Then later I got a call from Great Britain to officially confirm. I said, okay. Anything I'm supposed to do about that? No. I said, okay, fine. And then after, I've been trying to figure out. But then I began to go back now to look at the history and find out who all have been time president the year before. And I'm like, now I'm seeing why people keep calling and saying this thing over and over. Another thing I realized, I think Liberia as a country, many persons still, like myself, do not know what it means. It's time pressing. So I think they don't really move any president, except my former president, Madam Salif. In government, she was one person who called me. Yes, who called me to say, congratulations. Thank you for what you've done for our country. Besides her in government, I don't see any other person calling for the president. I was very, very happy when the president called to say that. And I said to her, Madam President, thank you, but this is not for me. It's for I and the team. Because whatever I did was not done alone. We did it as a team. So what that did for me, I think popularity, and people got to know me here at Ghana. I got called to different places to speak at different scientific conferences to talk about our work. Yeah, I went to Great Britain, Canada, Ethiopia, Cameroon. We're here in the US to share our experiences and spoke at different forums. And then I think it's based upon this that the former president would have appointed me to serve at the chief executive officer for the teaching hospital in Liberia, because I had no political allegiance with him, not a full member of his party. And so when he appointed me, having won to serve as the chief executive officer, that also came as a surprise. Until one day he told me about our engagement during the Ebola crisis. And that's when we became friends, meaning President George Weah, the former President Weah. And that's how I got into government. But my goal was to continue in humanitarian services. However, having said that, there was another negative part of being recognized as a term person of the year. One was, initially, there were a lot of misconception. And people were like, I've been given lump sum of money by time, several thousands of dollars I did receive as becoming town president of the year. And it was hard to explain to people that look, it was just an ordinary recognition without any monetary value. Say, no, it's not possible. So even my team members that work with me at the unit also had such belief. So people were like saying things, and I was like, why people don't want to believe me? That this is just a mere recognition of there's no monetary value attached. And it's for all of us. Until it went as far as having armed robbers to break into my house. About 8 of them. On ground that I received a lot of money from time, and I was making the money available. But they threatened to rape my wife if I did not make the money available. Beat me with collars and said, give the money. If you respect the money more than your wife, we rape her and And I was like, I have no money. And they collected my computer, my wedding ring, and every cent we had, took them away, and said, if you don't make the money available, we'll come back. And I was like, I don't have money. I've got no money from becoming time president of the year. So if you guys want to come back, you can come back. I remember then thereafter, a few of my friends said, ask for political asylum and leave this country. Because people may harm you because of this and that. Am I running? The truth is, I never have money. So I've told them the truth. If they want to come back, they can come back, but I'm not running anyway. Because I still feel I have more work to do in Liberia. I still was committed to the provision of quality healthcare services in Liberia. And saw no reason why I should ask for asylum. I know my son, my first son, was not happy about that. Because he was one of those who was saying, leave this country, we don't want to lose you. I said, not too happy. We stayed. So for our part of the world, I think this recognition get to be misinterpreted by others who don't understand what they actually mean. Okay, but that's it. If you but today we still, I'm still happy that that was done because I'm using that to see how I can reach out to people and see how we can contribute to the improvement of healthcare delivery in Liberia. I think this is the first time I'm talking about this aspect of the whole time president of the year scenario. I chose to just stay from the press days. But
so with that, could you share what you're currently working on, where your energy's focused now, and then maybe share a bit of the work that you'll be doing with Gorma's organization as well in Liberia?
Yeah, okay, thank you. Since I left the JFKMC Medical Center in February this year as a result of a change of regime, I've been focusing my mind on humanitarian work. See how I can work with different healthcare providers to boost private sector health provision, healthcare, mainly in the private sector. And so I've been thinking about how to work with other healthcare providers to ensure we brought their institution or services to a standard that is comparison to what we've seen in the West or seen to other places. Because at JFK, when I was serving as the Chief Executive Officer, that was one of my major goals, but it was difficult to bring about the transformation I envisaged because of a lot of bottleneck challenges. And so now I said, maybe working with newly institutions who have not been corrupted with different views and ideologies, one can strengthen them, work with them, and see how we can develop them to provide quality healthcare services to people. And that's how I ran into Care Africa Medical Foundation, as well as the Absolute Healthcare Foundation. I'm currently working with the Absolute Healthcare Foundation to do cleft lip and palate repair in Nigeria. That's free of charge, with support from SmartTrain. So we go across the country, look for children with lip and palate deformities and do the repair. And met Gorma and thinking about how we can give them a support with my vast knowledge in healthcare strengthening, healthcare infrastructure development, healthcare policy, and see how I can work with them so that we can ensure that people in that part of the country also appreciate quality healthcare. Because many of these services are offered in the urban setting of the country. Those in rural setting do not have good diagnostic opportunities. Okay, and the services there are still dismal. So there's a need to also support the private sector, helping to provide quality healthcare services to the people in the rural part of the country. Okay, I don't know what I'm trying to answer your question.
No, thank you. And then to wrap up, we like to ask a so what question. So again, if you're speaking to the international organizations, the regional organizations, the donors, what's the piece of advice or recommendation that you'd like to share with them as they both allocate their funding globally, implement programs, and as their goal is localization with, again, various meetings from organization to organization on specifically what that means. But what's your advice for those organizations on how they can best support you and your team, organizations like GORMA's, to deliver impactful, sustainable results?
Okay, thank you. I think one of the things I will first urge our international partners that are working with us to do is first maybe form a strategic monitoring and evaluation team. Maybe that is board of government to serve as an independent watchdog to figure out how healthcare services are being delivered, and among themselves to be able to determine where to direct their resources. And through that mechanism, begin to look at work that are done by other partners, one another, and be like a watchdog for each other. So that, for example, if an organization like the MSH is a unit, is a UC sponsor, it's an entity that sponsors some of UC projects, and GRZ is another group, I think, from somewhere in Europe.
Germany, yes.
Germany. To see whether what GRZ is doing is actually right for the people. Sometimes medicines are not true.
And do you think that role can be the government of Liberia, or there should be also some third independent
I'm thinking
oversight?
About a third independent and or the NGO themselves, because at times those in leadership, because they are receiving support from this organization, are afraid to look into their faces and tell them the truth.
Mm-hmm. Sure.
I know what you're doing is wrong. I know when I was at JFK, I spoke frankly with one of them, and I don't care. If you're bringing care for my people, it must be quality. Because what you see in the United States, bring the same standard. You can't have standards in the US, but when you come to Liberia, then you want to lower the standard. No, it has to be the same. And I think if we stood up to this organization, and also being sincere from our end also, because if you're standing up to someone to tell them about the truth about what they are doing, you too should also ensure that you're being fair and transparent in what you do. But because of our failure to be transparent from our end, makes it difficult to criticize others when they are doing wrong. It's difficult. It's because you're not transparent enough. You're not dealing fairly with the man. Already, you sold yourself to him. And because of that, it's now difficult to criticize him for the wrong he's doing. But if we could just be frank and fair with these donor partners, telling them our agenda, let the partner know what we want, and work along with them for the benefit of the ordinary people, the vulnerable society, women, teenagers that are getting involved in illegal and legal abortion. There's now the issue of addiction. Drug addiction is now a major problem This is a vulnerable population. But one thing I want to share with some of our partners is that I think investing in the private sector is also essential now. It doesn't have to be all of the private facilities within the country. Or who put together a pilot project, come up with a benchmark of what we want, and then evaluate a few facilities, say for example in Grand Bassa, maybe 2 or 3, and work with them, telling them the standard we want, and work with them over time. Then we're going to give you donation or going to give you grant, except you fought to ensure that this institution got to this level and this is the type of services we want for people to get. And at the same time, monitor them. If you don't do it, we withdraw our support. Okay, but again, to do that, we have to go on the have to outline what we want, know what the people needs are, and work with them. But I think, as I said earlier, knowing the country agenda is also important as you come in with your plan, so that it works in line with what the government has planned for our people. Because it's the government people, it's not your people. We want to help, I agree. My children are my children. They come to help me. But I should know how we want to help my children. You have to ask me what plans I have for my children. Then and only then we can work together to get them to become what we want.
Dr. Brown, we'll end with that. Thank you for taking the time to share your expertise and your insight today.
Thank you, Mike.
I enjoyed our conversation very much, and it was a privilege to have you on the Aid Market podcast today.
Thank you, Mike.
All the best with your important work, and we're always happy to share it however we can going forward. So thank you very much for taking the time to speak with me today.
It's a pleasure.
Thank you.
Thank you for tuning in to the Aid Market podcast. If you enjoyed today's show, be sure to subscribe wherever you get your podcasts and connect with Mike Shanley on LinkedIn to stay updated on the latest USAID funding trends.